Hey everybody, as we are all settling in, it's really good to see all of you fine folks here. Some of the faces in this audience I actually recognize already with my short time here in Washington. So my name is Karl Heward. I am actually the Neuroimmunology Fellow, and I've had the great opportunity here to talk with one of my mentors here, Dr. Shuvro Roy. And so we'll get started, but if you want to just talk a little bit about yourself, and then we'll talk more about SPS.
My least favorite subject, but sure. And I'll quickly say that we are fortunate enough to be, certainly training Karl in, many all things neuroimmunology, including stiff person syndrome, and he will be staying in the area, not quite in Seattle, but you said Lake Stevens? Or no?
No, so I'm actually going over to the other side of the Puget Sound. So, we've had a few talks about it already, but I'll be practicing over in Silverdale.
Yeah, so, which is just wonderful, because I mean, we were, oh my gosh, Tara, we got to add him to the list. Duh. Sorry, Tara was just asking me like, hey, who are the providers we got to add to, who actually see SPS, and it was like, well, I guess I should be on that list, but we got to add Karl, and we got to add a whole bunch of folks. So, Karl is really, even though he's quote unquote our fellow or a trainee, at this point we really view him as a peer. He's been such a tremendous addition to our clinic and helping facilitate clinical care and research, and just such an extraordinary enthusiasm for everything in this field. So it's great to share, I guess, the stage with him today.
Well, Dr. Roy, thank you so much for that really kind introduction. Believe it or not, I'm the moderator here. So, anyway, and I would just echo all the same kindness, not only to Dr. Roy for being such a great mentor while I'm here, but also to all of you. I must say that having practiced in other states, Washington patients are some of the most kind patients I've interacted with, and some of the most funny patients. So you were all very relatable, and
I remember you were sarcastic, and I love you're my favorite fellow so far.
Thanks. I did not pay her to say that. So.
It's a Pacific Northwest.
Yeah, and by the way, when you do have questions a little bit later, we'll have to make sure to give you a microphone so that way it gets into the recording. So just to repeat Jill's comment real fast, I'm her favorite fellow. So now that's recorded. So until next year, when they're your favorite fellow. So SPS, stiff person syndrome. I would just like to really think about that. Think about, from like the most simplest to the science to the treatments, things like that. And so, luckily we're here today, with a specialist, Dr. Roy. And so really, as we kind of dive into the stiff person syndrome, I think the first place to start is kind of surface level, right? If you are a patient who had this diagnosis, like, what does that look like for your life in that moment? What does it look like going forward? What can one expect? Like, tell us just like on the surface level about stiff person syndrome, Dr. Roy.
Yeah, absolutely. And I realize I didn't actually even answer your first question about talking about myself, but I'll try to speed run through that. Basically, I've been seeing patients with SPS for, I guess this is now year 5. Was like many folks, I had heard about the condition when I was a neurology resident, and you'd maybe see a patient or two, but that the experience, and I'm sure many of you run into this, was, well, we don't actually know if this patient has SPS or not, and most of us have never seen a patient, and that eventually actually inspired us to. 2 years ago, we did a nationwide survey of providers, and we learned that actually most providers have not seen a patient with SPS. And so then I went and I trained at Johns Hopkins under Dr. Scott Newsom, who is really one of the premier folks who I have to give a lot of credit to, built a clinic for patients with SPS at a time when he went to the chair of the department and said, "Hey, we need to establish a clinic for these patients." And he was told, "Well, okay, so what are the treatments?" "Well, there's not really a treatment at the moment for these patients, but there's a need, and there are a lot of folks who are underdiagnosed or not diagnosed, and more importantly, they're just not getting care." And by the time that I had come through, his clinic is what I think is it 200 some patients? I'm using the registry that we created in his clinic. So it's 200 some patients who have been seen with SPS, and when we look back in 2001, when this condition was first described, called stiff man syndrome, ironically enough, because overwhelmingly patients with this condition are women, and so at least we've made some adjustments in the nomenclature, and then really expanding upon that to what I refer to now as stiff person spectrum disorder, where yes, you have your patients with classic symptoms, thoracolumbar rigidity and spasms and spasticity, but also many other conditions, many other issues. Some patients who have cerebellar ataxia, for example, in my clinic, patients with cranial nerve abnormalities, and then even beyond that, where we're in some debate, is some of these other conditions that present quite differently that are associated with the same antibodies: GAD65, limbic encephalitis, GAD65, pure cerebellar ataxia. We, go through these debates in the community of, okay, well, what do we categorize as just being part of this one umbrella versus something else? And so, it's been quite an evolution over the last, I suppose, 20 some years of really identifying this condition, and then how it has grown over time. Like we said, we have those hallmark symptoms, but we're still learning constantly. We still don't have the pathophysiology nailed down of what seems to cause these muscle spasms, what causes this progressive spasticity and stiffness over time. But we're making progress, I think, and thankfully now we're starting to, more importantly, build the infrastructure to answer those questions.
Yeah, and one thing that I would say too is, with stiff person syndrome, I think an unfortunate part of a lot of our stories is the time till diagnosis, and having providers maybe write off your symptoms and things like that. And so I just want to speak to the heart of that. And so as we talk about, stiff person syndrome, like you've said, there's many different symptoms that someone might feel right now. But, tell us a little bit more about those symptoms. Tell us, typically, how, one would feel when they have stiff person syndrome and what their day-to-day can range from.
To answer that, or you want them to answer that?
But you can talk about it briefly.
No, I mean it's a good point. There was a paper that we put out. Oh gosh, I don't remember when we published it, but it was recent, within the last year or so. And basically, we looked at exactly this. Diagnosis of SPS. We currently don't actually have clear diagnostic criteria for this condition. There have been ones that were proposed again in 2001 by Marinos Dalakis, who's one of the forefathers of leading our discovery of this condition. But it's been 20 some years. It's time for an update. And so we put out a paper looking at what are the most common features for a diagnosis, and one of the tidbits in there was that actually of patients who eventually were found to have SPS, of those 200 some patients, 62% were misdiagnosed with something else along the way. So I'm seeing a lot of folks nodding. I would imagine that has been a similar experience, and that's because these symptoms, stiffness is not a specific symptom that just nails down, okay, here's the one condition that can cause that. Kind of a partner paper to what we put out was one by the I believe the Mayo Clinic, and they looked at, well, what were patients who did not have SPS, what did they actually have? For example, they found a similar sort of proportion where a lot of patients actually had something else. And so some of the other conditions included things like, something as simple as an undiagnosed herniated disc was actually quite a common thing, where that starts to compress on the spinal cord. You get this lower extremity, spasticity, some weakness, certain, even bowel and bladder issues. Other things were completely different conditions like Parkinsonism and Parkinson's disease, which can also cause rigidity of the musculature. And so oftentimes what we tend to see for patients with a history of SPS, or eventually making a diagnosis of SPS, when I am in the room, there are going to be very targeted questions that we start to ask, and this is part of the challenge, where these aren't necessarily the typical questions that we ask for just essentially all patients with neurologic disease. We have to ask very targeted questions. So, for example, patients may endorse, yes, I have this spasticity and stiffness that is isolated to one limb, is maybe worsened over time. But when we then looked at, okay, what were things that were predictive of a diagnosis? The triggers were incredibly important. And this is going to come up probably if we talk about seronegative patients, but so there's very specific triggers that tend to worsen things in SPS, and that these are things like loud noises, surprises, even like sometimes even bright lights. And so oftentimes we want to make sure that, okay, well, if somebody's complaining about progressive stiffness and spasticity, we want to make sure that we are asking about what we call these hypersensitivity triggers. The location of presentation is quite important. Classically, we're going to see the lower back, abdomen extending down into the legs for probably the most common antibody, anti-GAD65, but also glycine receptor. But then also if somebody says, hey, it's only in my upper extremities, well, all right, that can be associated with another type of stiff person syndrome. So those are all pieces, as we're just initially starting to make the diagnosis, are what, at least as a provider, what I'm asking in the room.
Yeah, and so once again, just to say, he's such a font of knowledge, right? So it's really nice to, get some of this perspective. One other thing that we don't think about is when we have a rare neurologic disease, we often wonder what other symptoms we have could be related to that disease, right? So you wake up and you think, oh, is this my SPS? You go to the store, something happens, is this my SPS, right? And so I think a question that a lot, for example, on some of those very same papers, agoraphobia, right? Being afraid of not being able to escape a situation, right? And I think that, once again, many patients with SPS can feel worried that they might have a muscle spasm episode in a place that would be inconvenient, but also other reasons, right? And so I think a good question would be, what are some of the other symptoms that we, don't think of as classically stiffness that a patient in this community might experience?
So I'm really glad you brought up the agoraphobia, because that was something that was really surprising to us when we were putting that paper together. But it makes a lot of sense where, if you are worried that, okay, if you don't have something to hold on to, that something horrible could happen, you could have a bad fall and you could injure yourself. That was actually one of, at least of the clinical history, one of the most predictive features of somebody having stiff person syndrome, which is just interesting because it's just not something that you typically think of as a classic predictive symptom. So in terms of other symptoms besides just classic stiffness, spasticity, I'll briefly bring up there, of course, what we call almost these billy goat like spells, where folks can have just this sudden full body spasm, and folks are obviously quite at risk of falling. A lot of our patients actually endorse some other symptoms. For example, even just GI issues was something that we were quite surprised to identify in a paper that I was not directly part of, but one of my good friends had put out in her training, that a lot of patients can have, perhaps it's related to this abdominal musculature stiffness that may lead to worsened issues with, say, like constipation. There is also the fact that SPS is associated with many other conditions that are not necessarily directly neurologic, but are associated with this anti-GAD65 antibody. So, for example, that could also be related to patients often have autoimmune diabetes or type 1 diabetes. Patients may have bad thyroid disease. They may have celiac. There are also even other autoimmune conditions like vitiligo, which can affect the skin. So those are some other symptoms that folks can experience, and then that also doesn't even include what we call the SPS plus phenotypes, where folks can, if this stiffness and spasticity wasn't enough to deal with, now you start noticing, oh, my vision is kind of jumping around, or I'm getting double vision, and that could be one aspect there. Ataxia, or basically this incoordination, whether it's in the legs, whether it's in the arms, and essentially seeing that there is damage occurring to the cerebellum, which is a center for coordination in the back of the brain. That's another type. And then on top of that, you also have one of the more challenging phenotypes to treat, which is, we'll call it PERM for short, nothing to do with the hairstyle.
Yeah, not the hair.
Progressive encephalomyelitis with rigidity and myoclonus, and that is the only time I'm going to say that one. But where you get this twitching, myoclonus, and jerking of the extremities. And so, as you can kind of tell, there's a wide variety of symptoms that patients can experience. So, understandably, a lot of times after even we make the diagnosis, we're usually spending several other visits of, okay, well, trying to tease out, well, what does sound like it could be SPS related based on what we understand at the time, what may not be, what are other, what could hint that, okay, yes, this patient has SPS, but there may be other conditions that we need to be screening for or re-screen for, because at least in my patients, sorry in advance, or sorry in retrospect, we drew probably a lot of blood, the first time you saw me, just to screen for some of these other conditions. And so, even if they're negative at the time, maybe we need to recheck later. So, there's a wide spectrum, and we are still trying to tease out what exactly is tied to these antibodies and what is not.
Yeah, and just to emphasize that, the GAD65 antibody is associated with a lot of things, right? Not just neurologic things. And so it's a good reminder to have a good connection with your primary care physician, making sure you do all of your regular screening. And, part of the reason why you're here, right, is have the skills to advocate for yourself. For example, have them check your thyroid, have them check your A1C. I think that's really important. All doctors' visits feel rushed no matter how much time we all have, right? And so taking a moment before your visit to have some goals and make sure to ask for those things. And same deal when you're visiting your neurologist. We have some fortune at UW, in my experience, that you have plenty of time to tell me what's going on. So make sure you tell me about all of your symptoms. Those of you who've been in visits with me, you might find that I ask, okay, what else? Maybe 5 or 6 times, right? Just to really make sure that we have everything on the table, right? Because you don't know. And so speaking of that, you might find in your own life now that you're actually a bit of the expert on SPS to the people around you, your friends and family, and other people might actually feel scared. Maybe they have the illness or whatnot, and so I think an interesting question to ask too is just, so if someone's concerned about this, what is besides just the GAD65 antibody in the blood, what are some of the other tests that we use to confirm this diagnosis?
Yeah, so, and this becomes important because, there are those small handful of patients who are seronegative. And and that's an especially challenging cohort to diagnose, because you gotta really feel good about everything else. So and just as a kind of as like the background on that, when we did that paper on looking at, okay, what were the factors that were most predictive of a diagnosis of SPS, the single one that had a 500-fold increased predictability than everything else we looked at was what we call a high titer GAD65 antibody. So, if it's through the roof, if it's quite high, I mean, there's not many things that can do that, and that's pretty convincing. So then if somebody does not have that, all of a sudden, okay, this becomes much more challenging to look at. And so there were a number of other factors that we look at. So if you've seen me, we've probably put you through a obnoxiously long EMG study. So where they basically are putting needles in multiple muscles to see, are those muscles activating at a time when they're not supposed to? Or do we have what we call...
I see many of you have been through that.
So agonist and antagonist muscles firing at the same time. Normally only one of those should be moving at a time. Other things that we do besides those two diagnostic tests are actually, there's an important test that we do at the bedside where over time, because of the location of the spasticity of these muscles, is they actually pulls the spinal vertebrae out of alignment, especially in the lower back. And so people get this misalignment of the vertebrae called hyperlordosis, which is where the vertebrae at the bottom kind of pull themselves forward, and we can actually feel that at the bedside, and that was one of the most important findings in a diagnosis of SPS. And so if somebody, say, doesn't have that antibody, there's you basically are making sure, okay, let's kind of run through a checklist of the things we just talked about. Are they having, their symptoms flare up in exposure to the right triggers? Okay. Not many things do that. That's quite different from many of these other conditions that we need to look for. Have we checked imaging to make sure that there's not something like a myelopathy or some sort of vertebral disc disorder that might be leading to this? And then, of course, what does the EMG show? And if things are otherwise looking like SPS, but all we're missing is a blood test, then we're probably going to make that diagnosis.
Right. So all of you experts in the audience, now you're ready to go forth into the world. So just to recap that, yeah. So when you or your friends go in, things like MRIs can be helpful for ruling out other things. The EMG, looking at muscles, right? That's a very, really important piece. Yeah, and then the blood work, right? And putting the picture together. That's another interesting problem that we face as patients, right? Where you'll go into the doctor's office, and like we said, with stiff person syndrome, it's really that lower back finding is really critical. But oftentimes when we go to the doctors, no one really looks back at your back or things like that, right? We get an exam and sometimes it maybe doesn't feel thorough enough. So same deal, I just want you to be armed with the tools in order to advocate for yourself and for your friends and family. And so the next piece, which in the previous talk, Dr. Roy had talked about a little bit, was treatment, right? Treatment for these symptoms, and how with stiff person syndrome, treatment is exquisitely challenging, right? But the other piece here, and I had mentioned it about you Washington patients, is, my mom once said, attitude is everything when it comes to this. And I think that you've all had a really good positive attitude as you push forward. But, besides a good attitude, what treatments do people use for SPS, and what can we expect? Expectations-wise, where do we land?
Yeah, so this is where, I think, especially compared to some of these other conditions, we probably have the most room for growth. But at least we've seen, one clinical trial that looked at IVIG, which really was so that was also done by Dr. Delacus, and what they found there was that for the most part, patients who received IVIG versus placebo were generally had better outcomes, or whether in terms of markers of their spasticity, or they had slowing of their progression over time. And realistically, that is often what we're trying to do here is, when we're starting somebody on an immune therapy, and I'll start there and we'll talk about the symptomatic therapies as well. When we're starting somebody on an immune therapy, that is really what we're trying to do. I mean, the challenge is because we don't exactly know what the pathophysiology behind this condition is. We know it's associated with GAD65 antibodies, but when we treat people with IVIG, they may get clinically better, but their antibody titers don't drop. They still stay really, really, really high. That's not necessarily the case with, for example, we did a study when I was at Hopkins looking at the same thing in MOG antibody disease, another condition that responds well to IVIG. When you treat patients with MOGAD with IVIG, their antibody titers tend to drop over time, suggesting that, okay, the antibody itself is quite directly, a pathologic. That is not what we see in SPS. And so we're still trying to figure out, in terms of our immune response, what are the best treatments that keep things under control. Most of it is targeted towards antibodies, like I said. So IVIG is essentially flooding your body with a bunch of different antibodies which may bind to, say, other antibodies or act on certain B cells or T cells or other white blood cells, and modulate the immune system in such a way that it's less active. Other treatments that have a little bit less evidence behind them. So, for example, we did a series looking at plasma exchange, which is where you are admitted to a hospital, you have usually a catheter placed in your neck or in your groin, and you are essentially washing the blood of antibodies. And what we found was that was really only helpful for acute, severe relapses, ones where folks were essentially left unable to walk, and that did improve their mobility afterwards. And sometimes a few rare patients will get that chronically, but there's essentially no evidence behind it right now. And then the things that we're hopeful for is, for example, some patients may receive a medication called rituximab, which has been used in a variety of different conditions, which acts on the type of white blood cell that produces antibodies, or B cells. Our hope, and I realize this is recorded, but our hope is that there will be clinical trials, maybe in the next couple of years, looking at essentially newer generation versions of that drug to then be able to apply it within stiff person syndrome. One of the manufacturers of those drugs may be here at this event, but maybe if you see them around, just make your presence felt. Use your voice.
And that is recorded now. So just to clarify, so as we talk about immunomodulatory therapies, if I'm someone who has stiff person syndrome and I'm feeling somewhat debilitated from my syndrome, will IVIG help then? It'll make me feel better?
Well, that's the hope. It's not a guarantee. I would realistically say it almost falls into three buckets, and depending on which studies you read, you will find different percentages for each bucket. But there will be that group that does see improvement in their symptoms, in terms of their mobility, in terms of their spasticity, in terms of their spasms as a whole. There will be those who things stay the same, and with where we're at as providers and with our understanding of this condition, we still consider that a win. Truthfully, is even if things are the same, we'll take that. And then there's also the group where, unfortunately, they will continue to have some decline or progressive worsening over time, but it is slowed down, and that is meaningful. If we're pushing off use of, say, a wheelchair by 5 or 6 years, I mean that is I think quite a meaningful change in quality of life for folks.
Quality of life, like years, are very important. I think we all can agree on that. And so, those are ways that we stave off. We try to stave off the disease as much as we can, right? With IVIG, for example. But then the next kind of piece just goes, right? So we're living our day to day. We have stiffness, right? We have pain. Maybe we have anxiety and other symptoms, right? We also have the great Dr. Ho in the room, by the way, who's a pro at those things. And so, but just speaking up here on this panel, what treatments do we have for those? How effective are they? What expectations might we have there?
So basically, day-to-day symptomatic medications. So there's a variety of different ways we can go about treating folks with regards to their spasticity. So usually we use a variety of different medications. I'm going to call them GABAergic medications. So GABA is a neurotransmitter that if you are, say, deficient, the nervous system is more excitatory, so you might imagine that could lead to things like muscle spasms. And then if you have more GABA in your system, that may calm down the immune system, or not the immune system, calm down the nervous system. That is a gross oversimplification, but we'll use that for now. So of those GABAergic medications, there are several. The most common that we tend to use in SPS are benzodiazepines, aka things like, for example, diazepam or Valium, clonazepam. I use both of those medications depending on what symptoms patients describe to me, maybe for something longer acting versus, for if their symptoms flare up over the course of the day. There are other medications that we use, baclofen, for example, as well as other things like methocarbamol, and then, other things, even just like Botox, for example, to help with stiffness in some of the larger muscles. And of course, the trade-off is, well, what does GABA do in the rest of your nervous system if it's quote unquote calming things down? Is, well, it can over-sedate people. And so, patients with SPS tend to tolerate much higher doses of GABAergic medications than those without. That is important to note because this is where patients deal with a lot of stigma. There have been patients of mine who've had to go to the ER, and then I get some sort of message of, what are you doing with these medications? What are you out of your mind with how much you're prescribing in terms of these controlled substances that in pretty much any other condition I would never use. And so that is, those are many of the different medications that we have in our armamentarium, and it's always, very much working with a patient. We talk about that term, shared decision making of, well, how is this working for you? Okay, if, some folks, need massive doses of benzodiazepines and they don't feel any sort of sedation, and others, unfortunately, are much more sensitive, and as a result, okay, we've got to walk some of this back. And it's really just about fine-tuning things over time, usually over many different appointments, to see, okay, well, what is working for you? And that's where, at least, we don't have any of the Swedish folks here, so we're fortunate, at least at the UW clinic, that we get to work with rehab medicine providers like Dr. Ho, like Dr. Simmons, who can also partner in taking care of those medications as well.
Yeah, so I know that we're running slightly over time here, so yeah, it's 2:00. So I think that we can either go to questions right now, or the last question that I would have, which would be about what could a patient do for their illness. What would you all prefer?
Well, I also have a question for Dr. Heward, because I kind of want to put him on the spot. Well, if you don't mind. So, because I think, what would be interesting, at least from a patient perspective, is to hear from a provider who is kind of going from that perspective of, okay, well, you were not exposed to many I don't know if you were exposed to any SPS patients over in Vermont before you started training here and you started seeing several of our patients with SPS. I'm just curious. I mean, what has that perspective been like? What has anything surprised you? What has stood out on your end?
So, I did see one person in Vermont. So, but anyway, but what I just one person, yeah, just like not even for SBS. No, just kidding. So what I would say is this is the most important part of training for any physician, right, is seeing patients, right? I've had a mentor in medical school say the difference between a good doctor and a great doctor is roughly 1,000 patients. And so all of you with SPS, when you let me come in there and ask you where you're from, right, that you're another exposure to making me a better doctor, right? And here I am, I've been a doctor for 4 years, and that's why they call it a practice, right? So what I would say is, the same culture shock I'd have with, taking care of Washingtonian patients, I also have with meeting you nice folks, right? And, once again, I became a doctor to take care of people like yourself. So, I think that seeing people's positive attitude while they are dealing with these symptoms, seeing kind of just everything from how you walk to what you deal with, right? So, the stiffness in your legs, your back pain, things like that, has all been very enlightening and eye-opening for me. All right.
I may need to run to
Yes.
another session, but do you want to tell them about what they should do from a non-pharmacologic standpoint? I feel
Sure.
like they've probably all heard it many times, but still.
Right. So, you may or may not know this, but the American Academy of Neurology is really focusing right now on brain health, right? Already, and feel free to run whenever you need to run. So we all know about a heart healthy diet, right? It even says it on like Cheerios, right? You get healthy for your heart, right? And so every other organ, healthy kidney diet, there's a healthy diet for all the organs. And so we as neurologists have essentially said, what about a healthy brain diet, right? It's good to have a healthy brain, right? And so you might see online, all various like anti-inflammatory diets and supplements and things like that. And the real answer is more boring than that, unfortunately. Every year they put up a list of diets, like the best diet to be on, and they rank them, right? Where does the keto diet this year, right? Who you rooting for, right? And again and again and again, the same diet always wins, which is the Mediterranean diet, right? So that's a healthy brain diet. Fish, vegetables, all of the boring stuff. No, just kidding. The healthy stuff, right? So a healthy Mediterranean diet is good for any brain, including yours, including SPS, anti-inflammatory, all of the stuff. Mediterranean diet's helpful. That, and then exercise, right? It's harder to do for people in your shoes, but persevere, push on. The healthiest thing for any chronic neurologic illness is movement, right? As my friends in physical medicine rehab would say, motion is lotion, or at least my PT wife says that. So that'd be the main important thing to do.
I'm sorry, everyone. I got to run two rooms over, but I'll be back.
Alrighty.